May I know who will be starting first?
Dr. Marini.
Yeah, I'll start first. Hand up.
Yeah, okay, sir. I have pinned you for my video. Okay, I'm giving a countdown now. 5, 4, 3, 2, 1. You are live now.
Great. So good morning, good afternoon, good evening, wherever you are in the world, and welcome. Welcome to the next installment of Big Ideas in Trauma Care. And today we're very pleased to be presenting a Q&A webinar on proximal femoral fractures. I am Marinus Papyrus. For those that don't know me, I'm the president of the Trauma Society, the Asia Pacific Trauma Society, and I have great pleasure in welcoming some terrific speakers, some world leaders and recognised experts in the management of these particular conditions. I have great pleasure in welcoming Ramesh Sen. He's Professor Ramesh Sen. He is a member of the AO Trauma Expert Pelvic Group. He is the President-elect of the Indian Orthopaedic Association. He is the Director of the Department of Orthopaedics at Fortis Hospital. Welcome, Ramesh.
Thank you.
I'd like to welcome Roger Bingham, a very good friend and confidant. He's a consultant orthopaedic surgeon at the Royal Melbourne Hospital and the Epworth Hospital, and he's a great regional and international faculty for the AO. Welcome, Roger. And I'd like to welcome Mk Wong. Mk Wong's been a friend for a very long time. He's the head and senior trauma consultant at the Sengkang General Hospital in Singapore. He's a senior AO trustee in Singapore and is an associate professor at the University Medical School. So thank you, MK.
Welcome.
And I'd like to introduce Jiwan Kim. He's a good friend as well from Korea. He's a consultant at the Asan Medical Center. He's an associate professor. He enjoys his research and is a council member of AO Trauma Korea. Welcome. And of course, I'd like to welcome someone who needs very little introduction, Suthorn. Suthorn's the chief of BDMS Orthopaedics and Trauma Care. He's our past president of the AO Foundation. He's been an inspiration for a very long time. And one of the reasons why we have such great camaraderie and great fellowship in the Asia Pacific region, and why we contribute so strongly as a group. And we are the largest group in the Asia Pacific area and the largest and most diverse group in the world, and why we feature prominently in the AO teaching rounds. Welcome, Suthorn.
Thank you. It's a pleasure to meet you all.
Very good, Suthorn. So I'd like to now hand over to Damon Ya, who will introduce our first speaker. And just before he starts, I'd like to also thank the Asia Pacific Orthopaedic Association for their support in providing this webinar series, and also to Jamal Ashraf, a great member of our community, of our society, and also congratulate him, as we all know that he's now the second vice president of the Asia Pacific Orthopaedic Association, and he does a mountain of work behind the scenes in order to make these educational events work. Jamal, thank you very much. Over to Damon.
So thank you, Dr. Marinus, for such a nice introduction of all faculties. So today we have 5 topics for presentation from proximal femoral fracture, and we will start with one of the important topic which is very difficult to manage, that is femoral head fracture. And I would like to request Dr. Ramesh Sen sir for his talk. Over to you, sir.
So likewise, good morning, good evening, and I'm thankful to Marinus, Dr. Jamal, to have given me the opportunity to talk about femur head fracture. And this is one injury which, if you look, has been called with the name of Pipkin. And I feel that Pipkin has described at a level, but it needed more kind of a classification. So Brumback is the one which suits much better, and I'll go with Brumback classification for these injuries. What is Brumback 1A is also the Pipkin 1, meaning by a small fragment getting avulsed from the femur head, either by as an avulsion injury or by a hit injury in the inferior pole around. Separates out. If it separates out, many times after reduction, it fits back, as you can see down there. And in that kind of ailment, it becomes purely a dislocation. You can see at a 6 years outcome. But even if it is a separate fragment, which may even get resolved totally, and you may not see, this is a 10-year follow-up of the patient with almost a normal range of movement, except for little restriction in the rotation. When we have this fragment, it could be very small, just like this case with the bilateral dislocation, with the bilateral fracture of the fragment of the head, very small fragment and reasonably big one. This big one might require a reduction and fixation, which is what we did in that side. The other side, we just accepted it conservatively. Now, what can happen to this fragment if we do not fix it up? This fragment eventually stays over there, might resorb or might remain as a small fragment which does not bother, and this is a 5 years outcome. But many times this can malunite. Now, depending on the positioning of this malunion, it may not give a problem in the ability to sit and squat, but it may give in some patient, like this patient who had a problem, inability to really flex the hip joint. And in that scenario, we chiseled it out. And once it was done, he was comfortable to go back to his all range of movements. These days, now this fragment can be managed by arthroscopically for excision or as well as fixation also. But overall, the concept is that these fragments can be anatomically reduced. If they are not reduced, hip is stable, inferior to fovea, the fragmented, so it's not a problematic. And you can see in this series of 110 cases, non-surgical treatment was in 32 of them, primarily for the type 1 injuries. There was a paper which says that these cases must be operated upon to avoid avascularity. In reply to that, we published our reply that this is probably not the right justification for surgery, because even in our non-surgical cases, AVN rate was not higher. And our both comments were published accordingly. Now we go to 1B of the Brumback, where there is an associated acetabulum fracture also along with. Now, depending on the size of this fracture, it may be insignificant and the person can have a reasonably normal outcome. But it could be that this very fragment, as it is associated acetabulum fragment, may not become congruent, as in here you can see it out. So, and accordingly, the fragment is big. So we stabilize the acetabulum, we stabilize this fragment back, and this is a 7-year follow-up of this patient. If this is a bigger fragment, meaning by involving the superior part of the head also, now this is classified as Pitkin 2, and this is also classified in Brumback 2A. In this case, we do not have any option but to go for surgery, and this is again a 5 years follow-up of this surgery. We have been doing this case with the Smith-Peterson approach if the dislocation is reduced, because this fragment very well is on anterior-inferior side, where as we open the acetabulum, the capsule anteriorly, we can see this fragment, put it back, fix it with the screws. During this thing, we do use K-wires to have that manipulation of this fragment, and once it is done, we can fix it up. Now, here is a case where you can see this was a dislocation. When it was reduced, the fragment was 180-degree turn. So we went with the Smith-Peterson approach, we re-rotated it, we re-stabilized it, and subsequently, this is the outcome of 2nd year, and this is the outcome of 12 years of this patient. Another patient with the same kind of a spectrum of a rotated fragment during the dislocation, we derotated with the same Smith-Peterson approach. This is a 6 years follow-up, and this is a 17-year follow-up. Now, what do we see? By 11th year, the radiology starts giving the symptoms that it is going for a degeneration. And again, here we see there is significant, but patient is not symptomatic even with this kind of a situation. For the fixation of fragments, mostly we were using this PTCS by countersinking the femur head into that cartilaginous area. Subsequently, we tried using these Herbert screws, and in between we did use these biodegradable polypins also and the screws also, which were not visible on the X-rays after the reduction. The complication which can develop in these cases is primarily from the dislocation, just like avian. In this case, we could see it on the third year when he became symptomatic with this kind of a lesion. He went into curettage, and this is after the curettage and 9 years follow-up of this patient maintaining state. Now, from Smith-Peterson approach, then there started coming up that trochanteric flip osteotomy is a better option. But that very paper also describes that for isolated displaced femur head fracture through a modified Smith-Peterson approach is still in 80% is likely to give a good outcome. But with the time, eventually by 2015, many reports came as a surgical hip dislocation as a reliable approach. And this is the approach that you go either by KL approach or Gibson approach, go and have a flip osteotomy, take the flip anteriorly, and then expose the capsule anteriorly, expose the head out, dislocate it out, and then fix that fragment back to its position using K-wires. Once it is done, thereafter fix this fragment, and thereafter you can close this trochanteric flip. Now, this is a case with that kind of a situation. It was a dislocated head. We went with the flip osteotomy, reduced it back, and this is a 7-year follow-up with a good outcome. Another patient with the same kind of a situation, you can see with the flip, reduced it back, and this is again our 7-year follow-up, again having a reasonably good outcome in this kind of a scenario. But it does not mean that all our cases operated by this did not get avian. Some of the cases went for avian, and we were using this method of aspiration at the time of reduction also to anticipate it. So we were taking the MRI at 3rd month, which was proving this is one of our own work. And in that case, we were doing as a management whenever we could detect it early by core decompression and bone marrow style rusting. And this is her follow-up at 4 years after this management, after the initial diagnosis of avian. Another complication was arthritis. As I said earlier, radiological arthritis was developing early, but the patient at 6 years follow-up was still able to sit and squat. But by 9th year, he was really getting that difficulty. And by 10th year, he got ready for getting the replacement done, and which we did. And this is the subsequent follow-up. You can see the fixation of the femur head we had. Now, our problem in developing word comes from the delay. Now, here is a 21 years female, who came after 4 months of the injury. The problem here was that half of the femur head fragment was not even visible. You can't see it on X-ray also. And when we saw inside, it was not there. Now, that was the issue, what to do when more than half was lost. So what we used a same size allograft, put it back at the same position. We looked at MRI after 4 months, and this is after 2nd year. You can notice little protrusion over here. This is after 4th year, and you may be able to see how she is able to manage her going back, going forward. And there is a kind of a leap, but she's happy with this kind of a movement. Now we come to another level, that is 3A, which in Pitkin is 3, where there is a fracture actually of the neck femur, but no head fracture, which is described in Brumback 3A. Here it was a acetabulum fracture, so we fixed acetabulum fracture. It was a 50 and 2 months old injury, so straight we went for replacement. But our problem is this Brumback 3B, where the head is broken into multiple fragments. Now this is an issue. So this is whole of the head is in our hand. We fix it back, put it back. Once put it back, then 6 months later we had the viable head. But then this patient went to New Zealand. He came after 6 years from the New Zealand with this ability to sit and squat to a limited degree, but a kind of a head which is compressed but has got a reformation of the femur head in that area. The other patient, however, again a 17-year boy with the exactly same injury, we did exactly the same thing, was not so lucky, and we had a collapse very soon within 2 years, and we had to take this out to replace this head with the prosthesis. The literature is clear that in these injuries, except for very young patients, just like these two patients, we should not really attempt synthesis. We should directly go for a replacement in this kind of issues. The other kind of a fracture is indentation injury, which can happen in operator dislocation, just like you see here. Now, the question is whether we should reduce them. At least these patients in our follow-up have not done bad. This is another case. One side had a fracture neck femur, another side has that indentation. You see this indentation is manifested here. This is him after 3 years, and then this is after 6th year, and this is after 8th year. He doesn't have any issue with his abilities. The other side screws are also out, everything is out, and he is okay with this kind of a case. The other thing which can happen to the femur head is sleeving off, a shearing off, which here even we are not able to see it. But after 7 years, when we recalled him, that fragment was also visible, a fragment. He was a happy man without any issue with the hip joint. But if this fragment is a bigger fragment, in that scenario, we will have to fix it up. And here we fix it up, and this is his subsequent outcome. There could be another issue that rather than a fragment, it is a osteocartilaginous cover only. And now it is an issue because you can see it is right at the weight-bearing dome, and this all cover is with our hands. So what we did, we again put some K-wires, pushed, stabilized with multiple harbor. You can see that small flake over there. Wire was also lost in between. And this is a subsequent outcome. We got an MRI which showed a reasonable viability, but we were doubtful about this cartilage. Subsequently, at 9 months follow-up, he was still okay. He could still walk. The limb was still there. We are observing him right from the subsequent outcome. The literature also says that these kind of the injury, you can put a kind of a graft in that area, just like mosaic-plasty can be done. So it is a mosaic-plasty of his own area for his own surface, which has traumatically advanced. Now the last is from back 5 injuries where the femur head is broken along with the anterior column injuries. And this is way back in 1997 when I had this case. I used a Smith-Peterson approach through which I could fix the femur head, as well as using a iliofemoral approach extending proximally, I could fix the acetabulum also. And she's 10 years later, she became arthritic, did a replacement, and this is her 19 years follow-up right now with the same surgery. Now, an unusual presentation is when the lower part of the femur head is present, but only the superior weight-bearing part is gone. Now, this is a difficult scenario because all the weight-bearing part is proximally, and here in this patient, I replaced it back, but the fragment was getting into avascularity. I removed this head thinking it is the cause, but by 3rd year, things were reasonably bad again. He had a difficulty, so I had to go for a replacement, and this is subsequent follow-up. There is another case, again, same kind of a scenario in a 23 years young girl who got this injury in 2010, and you can see it out, the major fragment, a small fragment anteriorly, and the weight-bearing portion lying posteriorly. Now, this was a very bad situation because all the superior part, the articular part was gone. So what I did was I reconstituted all those fragments, put them back into the situation with the inferior fragment, fixed them back, and after that I reduced. But within 2 months, I knew that things are not likely to be good because you see, this has gone for alien kind of a situation. And by 11th month, things were reasonably bad. You can see it out, the X-ray was quite bad. I knew that this screw is getting long, so I operated and took out this screw. But if you look at it, she was able to bear weight. And if you look at the gait at that stage after removing, she was able to walk around. She was not having pain. And that was this thing that I avoided doing anything more in this kind of a scenario. And 3 years later, she responded back, she showed back, and this is the kind of the hip she has got. It was a reformation of the femur head. And just last year in 2020, I recalled her back on WhatsApp now these days. So she came back with this ability that her head has reasonably formed back again. And this was the head. Now, when I asked her, how is she walking? And then she sent her video of her walking ability, and you can see it. So we had published all that in our paper recently of a series of 138 cases. Primarily in our country, we are not getting these cases very early in the time. And an interesting thing we observed that when you're operating on these cases, whichever approach you have used, the avian rate has been same, whether it was GANS, whether it was SP, whether it was a close reduction. The another thing we noted was that while 50% of the patients will be radiologically normal, clinically normal, many of the patients will be clinically normal while radiologically osteoarthritis or AVN was still there, and there were very few percentage which required. So after this publication in 2009 and subsequently in 2021, our perception is that these fractures, when they are Brumback 1A or Pipkin 1, can be managed by close reduction. Some cases might need open reduction or excision. When it is type 2, they usually require open and fixation. Usually Smith-Peterson approach, I feel, is better if the hip is reduced, and Gans approach if hip is not reduced. Brumback 3 fracture usually will require replacement. Only in very young you can do fixation. Indentation, we have not found them to be giving problem, but sheared off fragment must be reduced. And Brumback 5 usually invariably required fixation. And I'm thankful to all these patients who have been with me for this presentation. Thank you.
Thank you, sir. This was a comprehensive talk. We have some questions from floor. So would it not be better to excise the fragment than have a malunion later on?
Yes, if the fragment is likely to be, there is a concept that there is a fragment because this is always antero-inferior. So invariably, it doesn't give a problem in a Pipkin 1 type fragment. So it is not a problem. But if you feel the fragment is bigger one, in that case, it is either excision, but because it is a bigger one, it's better to fix it back. If it is a small fragment getting in the joint, you have to excise it out.
And so another question is, why did you stop using bioabsorbable screws for fixation?
This was coming from a company, and what we noticed that cases where we used intra-articularly the degradable things, the joint developed a lot of discharge from the joint, and which was a problem. So we complained to the company also, which was provided. Eventually, they retracted it back.
And the subchondral decompression, subchondral depressions are often seen with the femoral head fracture. So how should they be managed?
The subchondral avulsions you're talking about, which we had?
Yes, sir. Yes, sir.
There are two things. One is the separation of the chondral fragment along with the little of the bone, as I showed in that case. So there is a very minimal purchase, you can have it, but you have to be carefully reposition it back, just like we do in a chondroplasty, mosaic-plasty also, it's the same kind of a thing. But I was surprised to see indentation fracture, we are asking them to be reconstructed back. But our perception is that if the majority of the area is weight-bearing and is intact, then small area of indentation actually does not make a difference. So indentations probably, if they are not exactly in the weight-bearing dome, can be left as such.
And why is heterotopic ossification more with the anterior approach? So,
the heterotopic ossification has been rather, I did not go due to the time, a lot by, there is a series by some Chip Rout series. He had 60% cases having heterotopic ossification. Our series of heterotopic ossification is somehow not very high because we were restricting to Smith-Peterson approach. But if you are going with the approach to Post-Operative, the chance of heterotopic ossifications are, because eventually it is a posterior dislocation injury, and that injury itself might have a correction.
Thank you, sir.
Good, David. We should move to the next talk now.
Yeah.
Thank you.
Over to Dr. Nosumi. Yeah, thanks, sir. So over to Dr. Nosumi to coordinate next presentation. So Dr. Nosumi, are you there?
Yes. So next up. So the next session is from Dr. Roger Bingham regarding femoral neck fractures. So Dr. Bingham, please start your lecture.
Thank you very much. I'm just going to share my screen here. Rainey, give me a thumbs up if you can see that. Okay, we're good. So the brief today was evidence-based management of femoral neck fractures. So I always start with my declarations. I have given a few presentations for a couple companies and a few dollars of institutional support. So a lot of this you can find in our article on Hip International, Evidence-Based Management of Neck and Femur Fractures from 2017. But the overview for today is going to be four main topics. So fixation, fixation versus arthroplasty, unipolar versus bipolar, and hemi versus total. Let's start with fixation. So really the trial you need to be focusing on is FAITH. FAITH from 2017 had just over 1,000 patients in 80 hospitals in 8 countries. It looked at hip fractures in patients 50 and over, and they had to be treated within 4 days for displaced and a week for undisplaced. The intervention was patients either got cannulated screws or a sliding hip screw. So the primary outcome measure was reoperation within 2 years, and the secondary outcome measures were osteonecrosis, non-union, fracture displacement, and death. They also did a couple of subgroup analyses there, as you see. The typical patient was a 70 to 80-year-old female, and interestingly, had about 1 displaced fracture for every 2 undisplaced fractures, which is not typical of the practice I see, but that's what they came up with. So the primary outcome measure, no difference in reoperation in the first 2 years with either those cannulated or sliding hip screws. The secondary outcome measure, AVN was lower in cannulated screws versus sliding hip screws. Probably not surprising given they had a high rate of undisplaced fractures. But for the more tricky scenarios, there was improved rate of fracture union and less complications with sliding hip screw, those with displaced fractures, basicervical and smokers. The second paper you want to know about is one from last year with the Lancet called Hip Attack. So Hip Attack looked at about 3,000 patients, 70 hospitals in 17 countries. They had about 1,500 in each group, slightly lower age group, so 45 years and over. And really the only definition was a low energy mechanism that required surgery. The 2 intervention groups were accelerated surgery within 6 hours of the diagnosis, or standard of care, whatever the usual standard of care was for that hospital. Their outcome measures were mortality at 90 days and a composite of major complications such as AMI, DVT, PE, death, and a few other things. So if we look at mortality, really there was no difference between those that had surgery in 6 hours or those that had standard of care. And if we look at the composite of other complications, likewise, there was no statistically significant difference in those that had surgery earlier versus later. I am, on my disclosures, I talked about my conflict with Dupuy. I do use this device called the Ephemeral neck system. For me, this has a lot of advantages over a combination of cannulated screws and sliding hip screws. And, this device is still undergoing a lot of studies, so we'll see what happens with that in the years ahead. Topic number 2, fixation versus arthroplasty. Let's go back through the evidence, the major papers over the last 25 years. We're looking at Hudson in Core in 98. Unsurprisingly found that undisplaced fractures were no real significance in difference compared to arthroplasty, but displaced fractures that were treated with fixation had a much higher rate of revision, especially in the elderly. Celia Rogmark in Sweden's done a lot of work on hemi arthroplasty, total arthroplasty, and fixation for neck and femur fractures. And this group in 70 years and older patients with a reasonable follow-up found a very high rate of failure, 43% in the fixation group compared to arthroplasty. Then this is probably the archetypal paper of the generation. It's from 2003 in JS American by Mo Bandari and most of the OTA. So this meta-analysis found that there was 20% AVN, 30% non-union in fractures treated with ORIF, and displaced fractures, 35% of patients required reoperation. And they found that if you had performed an ORIF initially, the rate of conversion to THR was 23% higher than if you'd done a hemi arthroplasty, which needed to be converted to THR later. So doing the numbers, they found that out of 100 patients with a hip fracture that was displaced, if you did a THR initially, you would have avoided 17 further surgeries down the track. This paper out of Scotland in 2006 was a randomized ORIF versus hemi versus total. Reoperation rate so much higher in the ORIF group compared to hemi and total. Better function of life and quality scores in those that had any kind of arthroplasty. And then this more recent paper, this looked at 4 trials. So this is Jared Sabloglian at Shock Trauma in Baltimore. And this looked at a review of 4 papers, meta-analysis thereof, of those with age over 60, 1 or 2 type fractures, fixation versus replaced. The key outcome measures were operation, reoperation, or mortality. You see here on the odds ratios there that all papers found in favour of arthroplasty for reoperation, whereas mortality was kind of more neutral for both of those. There was a lot of bias with some of the papers, the more earlier papers on plasty. Let's have a look at the Australian data. We see the fracture type intracapsular, either undisplaced or displaced, is about 45% of fractures compared to troch fractures and subtroch fractures. When we look at the undisplaced fractures, you see that nearly 50% there are being treated with a Hemi Arthroplasty and about 10% with a total hip replacement. We see that where the fracture is displaced, that goes up to more than 75% of Hemi Arthroplasty, and the remainder almost total hip replacement. So let's look at arthroplasty when we further consider Hemi versus bipolar. Probably the biggest study on this was Martin Parker, who looked at Hemi versus bipolar, analysis of 7 RCTs. He found that most of the trials had poor study design, but essentially between unipolar and bipolar, he found no difference in the major outcomes of dislocation, acetabular erosion, reoperation, and comorbidities. In the Australian Joint Registry, you can see here the line in the yellow, which is bipolar, has a lower rate of revision at every point in time, practically, than the unipolars. So overall, uni versus bipolar, there's honestly not a lot in it. We tend to use the unipolars more for less active sedentary patients, but in some studies and some registries, the bipolar arthroplasty showing better results. There's a lot of selection bias in this, though. Hemi versus total, well, there's a lot of papers on this going right back to 25 years ago with Laurie Dorr. So his paper found in displaced fractures, there was no difference in mortality, but the case in a lot of other papers you see is you trade off dislocation rate in total hip replacement for better function. And this was certainly found in Gebhard's paper in Core in 1992. The THR patients had less pain, better walking distance function scores, but the revision rate was higher in that paper, mainly because they were using a lot of Austin Moore endoprostheses, which were revised. Ravikumar and Martin injury in 2000, their paper looked at Garden 3 and 4 fractures. Again, the same sort of trend with better function scores in the total arthroplasty group, higher rate of dislocations in the total hip replacement group. So there's a constant theme there that you get better function with the total, but you've got a higher risk of total hip replacements dislocating. This paper by Richard Baker in Bristol was a fairly well-controlled trial in JBJS 2006. The only differentiation here was you got a cemented Hemi or total via a Harding approach. So it was a 28 millimeter head, reasonable follow-up of 3 years, better function with walking distance. But in terms of their Hemis, they had a low rate of dislocation, again, but a high rate of acetabular cartilage erosion. What do we see in Australia? Well, again, that yellow line with the bipolar is better than the monoblock unipolar, the modular unipolar, or the total at any point in time. The key thing with that is age. So if you look at this in the under 70s, you see that the dislocations and the other reasons for revision, such as loosening and fracture, are mainly in the under 70s. If you put a unipolar in someone under 70, there's a high rate of trouble. Over 70 in Australia, they're almost all doing the same, like you see on the graph on the right. This fits with a paper that's out currently in the JOA that we published. We found that when you had a hip Hemi for a fractured neck of femur, there was about a 10% revision rate, and what you did to that patient was more influenced by how old they were rather than what you did in terms of standard head, big head, dual mobility, or constrained liner. So the younger patients did worse if they had a hip Hemi convert to a total. So Hemis, we see here in the Australian registry data, why are they revised? Blowing that up a little bit, we see about a quarter for fracture and about 20% roughly for infection, dislocation, and loosening. This is heavily skewed in terms of whether you cemented the stem or whether you didn't. So the evidence shows that if you put an uncemented stem, the rate of periprosthetic fracture is very, very high. Compared to a cemented stem, the rate is about the same for all other causes of revision. When we compare that to a total in this chart here and then the magnified chart on the top 4 causes, dislocation is by far the most common cause of revision for a total hip replacement. Fracture, loosening, infection close behind. And you see dislocation there in the blue line is very significant in the first 2 to 3 years, way more common than any other causes. So when we have a look at the issue, we need an international multi-center randomized trial. Well, they gave it to us with the health trial in the New England Journal of Medicine in 2019. 1,500 patients, 80 hospitals, 10 countries. And what they looked at was a patient randomized to either hemi or total, whatever the surgeon would normally do. They were assessed at 1 week, followed by 3, 6, 9, 12 months, 18 and 24. Demographics were effectively the same across both groups, about roughly 750 in each group. The BMIs were identical. The functional status was identical. Comorbidities were identical. So the primary endpoint was any unplanned reoperation within 24 months. And you see that there's really no difference. So roughly 700 in each group, 57 versus 60, not significant. You see when they graph that over time, hemi versus total, they fluctuate with the higher rate of revision for the total, then the hemi, and then back and forth. And if you look at it on a proper y-axis, there's really not a lot in it there. The secondary endpoints were hip-related complications, death, and a variety of functional scores. There were better Wong scores, like the other papers we used on the total compared to hemi, but no difference in any other major scores. The conclusions were that hemi versus total did not differ between groups, better function in the THR group, higher incidence of adverse effects maybe in the THR group. The limitations were there was a short follow-up. You really can't do any kind of registry study in 2 years. You need to extend it much longer. They had a 15% follow-up loss for primary endpoint, which is reoperation, and their functional ability data was only complete in 40% of patients. So I have a big problem with this trial. I really wish it had been done a little more tighter. The inclusion bias is a big deal. Surgeons that chose hemi versus total and then took their patients out of the trial if they didn't think that was the right approach. Speaking of approach, anterior, posterior, and lateral, it's a big deal, as is the prosthesis selection, fixation, and interestingly, surgical ability, which I'll touch on quickly in a second. So the effective surgical approach. This is an article we published last year in JBJS, and this is for THR for OA. So we see there anterior, hard hinge, and posterior, absolutely no difference at any point in time for overall revision. This has been looked at specifically with THR for NOF and hemi, and we see here there's a slight bias of anterior versus posterior, lateral over posterior, and then anterior over lateral for dislocation. Similar sort of findings for reoperation, where posterior tends to be the bad guy. Infection, anterior and lateral number 1 and 2 again, but for fracture, posterior seems to have a lower rate of fracture of the other 2 approaches. This Tom and Mike House from Bristol in 2019, JBJS, they looked at all the UK joint registry data over the 12-year period, 2003 to 15. They looked at implant and patient survival. When we look here at the implant survival, interestingly, the hard hinge approach had a slightly higher rate of implant survival compared to posterior, but for whatever reason, the patient survival was better in the posterior group. It's hard to know what to make of that. Dislocation, subluxation, the most common cause of revision, yet again in that paper. So the effective prosthesis selection, this is a paper we presented at the Academy a couple of years ago and was recently published in Core last year, looking at standard head, large head, dual mobility or constrained liners when you do a THA for NOF. Here you see really no difference in all the bearing surfaces except for constrained liner. Constrained liner, way lower revision rate at any point in time. Certainly when you look at age over 75, that's maintained. And for females, really no difference. So age over 75 in females, that's particularly relevant. No difference in revision rates for the other 3 bearing surface. Constrained liners reduce your rate of redo surgery, especially in females and the elderly. But the revision reason for revision for the dislocation is the most common cause reason for revision in any bearing surface, whatever you choose to use. Fixation, quickly touch on the fact that with or without cement, Martin Parker, again, he looked at some meta-analysis of randomized trials, and he found that there was no increase in surgical complications with cement, better mobility, especially early on, and less pain at long-term follow-up. Swedish Joint Registry found the same thing, lower mortality and fewer reoperations when you use cement. And this article published again by Martin Parker last year in the BJJ. He looked at 200 patients in each group, cemented versus uncemented hemis. Key outcomes were mortality, which was higher in the perioperative period with cement, so that may be an issue for a very unstable patient. But overall, in the 2 years, overall in the 12 months, there were a higher number of deaths in the cemented group, 64, compared to the cemented group, 51. For function, there was no difference in pain scores, no difference in reoperations, but the cemented group had much better recovery of their mobility. This is an evolving topic. You're going to read a lot more about this in the next 2 years, but surgical ability, I'm telling you now, is highly relevant. This is a paper we had accepted in core a couple of months ago where we looked at the effect of surgical ability on the outcome. So we've got in green there the low revision rate. This is the surgeons in Australia that have the lowest revision rate overall. And you can see that this is again in arthritis, but a total hip replacement done for arthritis compared to all other surgeons. The surgeons that have the lowest revision rate have much better outcomes for loosening, for fracture, for dislocation in particular, half of all other surgeons, and for infection. And when you combine this with prostheses, in terms of prostheses that are known to perform well, known to perform not so well, this is a paper which we just submitted to JBJS. So this is what happens when the top performing surgeons in green compared to the surgeons in blue, exactly the same implants. So, forever we're told about its head size or bearing surface or fixation or this and that. But when we look at surgical ability here, you can see hazard ratios of 6, 7, and 8, which is something we just don't see in joint registries. It's quite extraordinary. And when we look at those same implants in under 55, performing a THR with an implant that's doing well in green compared to one that's doing poorly in yellow, it's an absolute tracing paper here. So there's no difference in what implant you use in poor surgeons under 55. So this is part of the topic we've been exploring of whether it's the implant that matters or whether it's your surgeon and the surgical ability that matters. But you'll hear a lot more about this in a few years. Anyway, top 4 things we've talked about tonight: fixation, cannulated screws versus sliding hip screws, certainly a low rate of AVN in the undisplaced fractures. Orif versus arthroplasty, there's really no question. Arthroplasty is better for displaced fractures and the elderly. There's better outcomes in terms of function and reoperation. Uni versus bipolar, it's controversial. There's not a lot in it. Maybe bipolar better for some patients in joint registry studies and some trials where there's a lot of selection bias. And hemi versus total, well, THR in active, healthy patients, but you do trade off dislocation for function. But as I said before, what is the effect of surgical approach, prosthesis selection, component fixation, and surgical ability? We will see. Thanks for your time tonight, and I'll unshare my screen.
Okay, thank you for your great lecture. So I have a couple of questions in the chat box. So first one is, what is your opinion on the new femoral neck system?
Declare my bias straight away. I do give paid presentations for that device, but I think it has a lot to offer in terms of resistance to varus force, loss of fracture position, and certainly the biomechanical studies are showing that it compares very favorably to cannulated screws or a sliding hip screw. It can be done through a very small incision. So again, I'm conflicted, but I do like that device.
Mm-hmm. Thank you. And the next one is, what is your post-operation protocol for the new neck system fixation?
Yeah, look, there's no operation that I do where I don't fully weight bear the patient with a femoral neck fracture.
And what is your cutoff age for internal fixation in femoral neck fractures?
Yeah, it's a good thing of biological age versus numerical age. So, we know that where possible, you're going to try and save the patient's head. But the reality is that arthroplasty performs so well, especially in the hands of somebody that's an arthroplasty surgeon who makes the right choice with bearing surface implants, or maybe with the trials we've seen there, it doesn't tend to matter so much. Look, if it starts with a 5 or higher, as in 50 and over, I'm going to try and replace it most of the time. If you're under the 50, I'm going to try and fix it. But the reality is I've done a lot of joint replacements in 30 and 40-year-old people where I've tried to fix them straight up. But I cannot give you a single number tonight.
Okay, thank you. And the last question is, do you do various osteotomy for non-unions, or do you just replace them?
It's a good question. So for non-unions, when you do an osteotomy, then you've got 2 fractures that need to heal. The original fracture plus then the non-union, plus the osteotomy you've created. When you do a varus osteotomy, you've created an obligate external rotation deformity, you've created a limb length deficiency, so you're introducing all kinds of error into the biomechanics. I personally prefer to do an arthroplasty, but certainly in the very young and those where head preservation is an issue, we'll refer those on to the osteotomy surgeons.
Thank you so much. That was the question. So shall we go to the next presenter?
Yeah, that sounds great, Natsumi. So firstly, the other thing I'd like to do right at this point in time is we've heard from 2 of our younger colleagues. They're Damon Yar, who's an associate consultant from Medicity, Kathmandu in Nepal, and he's currently doing a foot and ankle fellowship in Sirajaj Hospital, Bangkok. And obviously, we've just met Natsumi Sako, and I think it's very early in the morning in Canada, and we thank you for being available. She's an experienced trauma surgeon from Chiba in Japan, and she is currently studying for a master's degree in clinical epidemiology from McMaster's University, Ontario in Canada. So thank you very much for moderating for us. And now I'd like to introduce Christina Marie Joseph, a consultant orthopaedic surgeon at the Baptist Christian Hospital in Tezpur in India. She's an experienced trauma surgeon with a special interest in the management of open fractures. Christina, if we could move to the next one, that'd be great. And thank you all. It's great to have our younger surgeons participating and helping, and obviously getting to know everyone in this time of COVID. So thank you for your time.
So our next presenter would be Dr. Mk Wong. He would be briefing us on the management of intertrochanteric fractures. So I would request you to share your screen, sir.
Okay, can you see my screen?
Yep, it's all good.
Okay, good. So I'll fire away. So this is a refresh of a talk that I gave to my orthopedic association about 10 years ago. And unfortunately, I think for trochanteric fracture management, the topic has changed. It was used to be intertrochanteric management. In severe osteoporosis, I believe that we're still behind the curve. So I'll go through the epidemic we face with these elderly fractures. And in Singapore, it's getting worse because the people are aging extremely fast. So we're one of the fastest aging population in the world, even ahead of China. We'll go through some pathophysiology of osteoporosis and how it altered the biomechanics of the fixation, therefore predisposing the fixation to failure. But of course, nevertheless, we need to develop an evidence-based treatment framework. So what fractures are we dealing with? So this is 31A fractures, and in Singapore it's an epidemic. We have a lot of these. The conservative treatment is dismal, and I don't need to go there. But unfortunately, despite current surgical treatment, this paper was a landmark paper by me of Singapore, 1997, and it doesn't show a great functional recovery despite surgical management. And doing a search this morning, I only found this paper written in 2004, and there's no further update. But nevertheless, it's still running about 80% needed walking aids after a trochanteric fracture. So these are pictures of problems we have fixing this class of fractures. You have cutouts, which is very common in the days. And one might say these are old stuff, but these are new stuff. So despite the TFNA and the cement, I still have cutouts. Well, of course, the patients are older. The patients is multiple comorbidities and especially renal failure, which I can't solve. So what's the problem? The osteoporosis, a severe form of that, really challenges the fixation for these fractures. The problem is bone failure, pull-out or cutout, and periprosthetics. So today we're not going to talk about periprosthetics. We merely talk about the first operation. So in biomechanics of fixation, we aim to share load with the bone. And how we do it is to impact the fracture to create contact stability. The implant should be inserted at a place where the best bone exists, wherever they may be at that age group. So clearly, intramedullary nails have a better mechanical performance, and we no longer use screws. In the elderly, we use impaction blades to increase the surface area of contact. And in all my elderly patients, I augment them with cement. As I said, we're not going to touch on the periprosthetics today. So the next few slides is really a look at the history of how we attempt to solve the problems. The first is that we know that the center position of the hip blade or the hip screw is very important. Most importantly is where the best bone is. That's really the case. So the being lower, being posterior doesn't help. You have to be you have tried to be center at all times. And you try to be less than 25 millimeters on a composite measurement from the AP and lateral x-rays. Then the second thing we tried is the blade-shaped weight-bearing elements that exist in DHHS as well as the capsulomedullary nails. And we know that helped with prevention of cutouts. And these are borne out by biomechanics as well as clinical evidence. And finally, we went on to add augmentation. Now, obviously, there are many contenders in that sphere, but what has become common is cement augmentation. What is interesting, cement has done for the hip blade augmentation is that it helped the eccentrically placed blades much more than the centrically placed blade. So these are biomechanics evidence from Michael Bluff, and clearly it in a difficult, challenging situation where your blade cannot be in the center position due to reduction difficulties and so on and so forth. The cement is far more better for you than a center position. And what has recently come to the fore is the accuracy of reduction. So as we all know, in the trochanteric fractures, the posterior cortices are comminuted, and there is no ability for weight bearing in that transmission of weight bearing in that area. So nowadays, I try very hard to make sure the anterior medial cortex is well reduced to allow weight bearing. So you can see from this paper in 2020 that if you manage to get that anterior medial cortex aligned and weight bearing, then the shortening and the neck angle loss over the healing period is going to be a lot less. Look at the range of what's going to happen if you don't get the contact. Would be that in the you may lose up to 3.9 centimeters, which will mean that your blade is going to collapse out of its possibility. So if you manage to get the anterior medial contact, then the range is up to 2.1 centimeter. You have a sliver of hope to not have a cutout. And clearly, this is also reflected in the patient outcome in the SF36 and the Harris hip score in 1 year. So in summary, for biomechanical strategies in severe osteoporosis, we aim to anchor implants in the best bone in the center position. We aim to have load sharing rather than load bearing implants as well as reduction. And you will want to obtain a biomechanical robust fixation. And nowadays, for anybody above 70, I always augment with cement. Just a shout out to evidence-based treatment framework. One mustn't forget that these patients has multiple comorbidities, and the preoperative optimization and planning is extremely crucial. And the orthogeriatrician also helps me in my unit to allow functional rehabilitation after the surgical intervention. But today, we are all surgeons and we are interested in getting a robust fracture implant construct. So how do we think about this problem? The factors that influence the construct stability really is split into those you have some influence over and those you have no influence over. So if what the patient comes with comorbidity and the fracture geometry, they just end up on your doorstep and there's nothing you can do about it. But what the surgeon can then control is the ability to reduce it well, and especially in the anterior medial cortex. And you can, of course, choose an implant that will give you the best shot at the problem. And at the end of the day, after a difficult reduction, you will try and position the implant in the best possible way. So to understand, therefore, implant choice would actually be the understanding of the fracture geometry classification. And this is the current AO classification we all work with. And this is validated by CT scan classification that basically actually prove that this classification is robust. But note that the change since then has been a CT scan validation and not an X-ray validation of this new classification. In the fracture geometry, there are two elements that we work with. One is the lesser trochanter or the posterior medial calcar fragment. If that fragment is stable, especially after reduction, then you have a chance at putting a DHS, for example. But if that fragment is large and unstable and unreducible, then you are best served with intramedullary fixation. The second thing is the lateral wall thickness. If the thickness is less than 20.5 millimeters, no matter how the medial fragment looks like, it's going to be an A2 unstable fracture. So this was a slide that I used 10 years ago, and the question then was, in A2 fracture, you have a choice perhaps of doing a sliding hip screw with a trochanteric side plate. But I think with the next few slides, you will understand that that is not a very good option. So nowadays, for A2 and A3, only intramedullary device really is indicated. In the rare situation, and at some CT classification is less than 2%, you are really having a two-part fracture. So that's going to be rare in my series. So A2 unstable, and there are papers that show that the revision rate is extremely high. The reason is when you try and put a DHS in this position in these fractures, the reamer for the side plate and the barrel is going to cause a fracture of the lateral wall. And you can see that once the greater trochanter becomes mobile and displaced, you're going to run out of collapsing distance extremely fast. And then thereafter, if it doesn't heal, it's going to be a cutout. So one of the key elements that determine an A2 unstable fracture, again, to emphasize, is the thickness of the lateral wall. And you can see that even in this cephalomedullary nail, the reamer for the cephalic blade has already caused a fracture and movement of the greater trochanter. But the intramedullary nail has a much better biomechanics in preventing further collapse than the plate ever will have, despite a trochanteric side plate. So, summary again, if you have a A2 and A3 fracture, and then it really, really deserves an intramedullary nail. So the next thing I want to emphasize again is the accuracy of getting the anterior medial contact. The reason for that is in the case of an unstable fracture, you may end up having the head fragment into varus, medialization, and rotation. And only when you can reduce the anterior medial single fracture cortex, then you have a chance at preventing too much of shortening. What about prosthetic replacement? This has not been found to be very useful, chiefly because in an intertrochanteric fracture, the operating time and blood loss has been in various papers found to be 2 to 4 times more if you attempt a arthroplasty. So as far as possible, I would try and fix them. Then what about cement augmentation? It definitely enhances implant anchorage, and biomechanically, it's superior, resulting in better clinical outcome when patient undergoes rehab. And again, to emphasize, the involvement of orthogeriatrician in all phases of care is vital, and this has been validated in multiple studies. So my goals in these challenging elderly fractures is to get them assessed and stabilized medically, go for the operative treatment within 48 hours to achieve a robust fracture implant construct, and allow early mobilization. So in my hands, the cutout of the implants I use is about 5%. And the message out to the patient and relatives is that we expect 5% to fail, but at least in those, we have a chance at getting the trochanters to heal and an arthroplasty as a revision. If they don't get up and walk, they will die of pneumonia and UTI and sepsis in the first admission. So it's better to survive the first surgery and come and fight another day if we have to. So take-home messages. It is rare that I find stable trochanteric fractures that I dare to put at DHS. Because of the x-rays we work with, most often time I'm cheated during surgery, and I realize that there is no stability in the posterior comminution. For unstable fracture, they truly deserve an intramedullary device. And for all my patients, I wait there them the next day with a walking frame personally, because this is the study that I performed. And the ambulatory status at discharge versus death in a year, if the patient remain in a wheelchair, they're going to have a 26% mortality rate. If they are bedridden, it's going to be more than 50%. So my bias is to walk them the next day. Thank you for attention.
Thank you, Dr. Mk Wong. That's a very detailed presentation, very valid tips as well when it comes to the management of intertrochanteric fractures. So we have a few questions for you. The first one is, would you always use long nails in an elderly patient?
Okay, so that's been a debate, and sometimes the debate is with a patient's relatives. So I always use a long nail, and I usually do not lock distal unless it's a subtrop extension. And I think in the literature, the long or the short nail or the short nail with properly sized up to 12, or just any size will do. Some of my colleagues just use routinely a size 10. The studies are mixed whether it makes a difference. So I would say long versus short, long locked versus long not locked, short with appropriate size versus short with no appropriate size, just any size you like, and short versus long, all no difference. It doesn't make a difference. The difference, just as in the previous fracture discussed, is really the surgeon's ability to reduce the anterior medial cortex.
The next question for you is how large should the posteromedial fragment be so that it can qualify as an unstable fracture? How large should it be?
As long as that fragment doesn't stay in, it's unstable. So I have rarely met one where the medial calcar stayed in, and after you ream and put in the nail, it still stayed in. Or put in a DHS, it still stayed in. It always shifts. So in my series, I unless it's a plain two-part, I really worry about the medial stability, the calcar stability. So I really don't dare to put in a DHS for most cases.
Another question is, when do you start the patient on anti-ostroporotic agents, and also which agent do you prefer?
So for my hospital, the geriatrician takes care of that. And they will start the alendronate, bisphosphonates, if there's no contraindication, especially renal challenges, within the month. Depending on the BMD progress, they will go up to 3 to 4 years. In the renal failures, recently, because of the shifts of the head screw from the cement mantle that we witnessed within a month, I'm going on to teriparatide to try and hasten the recovery. So that is at this point off-label use, and we're hoping to get some data to publish.
Thank you. The other question is, what is your opinion regarding the tip apex distance and the calcar reference tag for proximal femur nail in an IT fracture?
The tip apex, I aim to be shorter than 20. So whatever you measure of the cephalic blade, I put it within less than 10. I don't minus 10, I minus 5. I don't understand the second part of the question.
I think they have meant like, what is your opinion regarding the calcar reference that as well? The TAD.
The calcar reference.
Cal TAD is what they've asked.
Sorry, I still don't quite understand the calcar reference.
Okay. The next one is...
That's okay, Christina. We may move on to the next one. That's all right, if that's okay. Yeah.
The next question is, when would you prefer a hip arthroplasty rather than bipolar?
Like I said, the arthroplasty options are not really favored in the intertrochanteric fracture, because there are multiple of studies that show you lose 4 times as much blood and 4 times as much time. So unless I can do a quick one with a calcar replacement situation, I rarely do arthroplasty for intertrochs. I try and fix them and get the troch to heal. And then if the neck portion doesn't heal, then we do an arthroplasty as a delayed because it cuts out.
Thank you, Professor Wong. I think we need to go to the next one now.
I think so.
Yeah.
Thank you.
Thank you.
Yeah. So the next topic is on tips and tricks managing subtrochanteric fracture. So I would like to request Dr. Jiwon Kim for his talk. Over to you, sir.
Kim, you're muted. Kim, you're muted.
Can you hear me? I'm sorry.
Yes, correct.
That's better.
Okay. My talk deals with the following topics. The first one is the characteristics of subtrochanteric fracture and implant selection, and the starting point of the importance of starting point and reduction technique. First, subtrochanteric fracture is defined as the fracture located between left trochanter and distance of 5 centimeters distally. It has a bimodal peak in young age from high energy injury, in elderly, low energy injury, including atypical femur fractures, especially common in Asia, in Japan and Korea. Both are challenging injury to treat surgically. Characteristics of subtrochanteric fracture considered for fixation as follows. First one is the deforming force by proximal muscle made a difficulty in reduction. Second, subtrochanter area is predominantly cortical bone, which needs biologic fixation. Wide open reduction and result in the neuronal infection. Third, the area is biomechanically high stress zone, so that needs a strong implant. This is the characteristic deforming pattern. So the external rotators make proximal fragment external rotation and abduction. And psoas muscle also make external rotation and flexion deformity. This deformity makes difficulty to determine correct nail entry point. Long entry point also contributes malreduction or deformity, like this one. In femoral shaft fracture, isthmus type, reaming or insertion of nail acquire automatic reduction. However, subtrochanteric area with a wider metaphyseal area has no effect of auto reduction. Therefore, nailing should be performed after satisfactory reduction. This is a typical type of malreduction. How do you evaluate surgical result in this case? In terms of reduction, a strong implant, biologic fixation, reduction, not good. Strong implant, no, because of no cephalomedullary screws. Biologic fixation, yes, he closed nailing. So there are two options of implant. One is intramedullary nail device, nail, and the other is extramedullary device plate. Mechanically, nail is better than plate because of shorter lab arm distance. In addition, closed nailing provides reduced blood loss, reduced infection risk, higher union rate, which results from biologic fixation. So the nail is winner. In the past, the plating was used, but open reduction may violate biology, high rate of reduction loss and fixation failure, and need for reoperation has been reported. I'd like to emphasize the following 4 surgical tips. The first one is correct entry point, reduction technique, and reduction and maintaining technique, and reduce fracture gap, not distraction. Correct entry point is slightly medial to the tip of the GT, not lateral to GT. When you start at the tip of GT, patient soft tissue mass, operative drafts of trajectory of the reamer or nail insertion easily enlarge the pilot hole in the GT laterally. The lateral placements of the entry point result in varus reduction and high position of screw, which indicates a poor result. Remember, slight medial to the tip of the GT. Intraoperatively, neutral alignment of the proximal fragment is important. Usually, proximal fragment is external rotated, so it is not easy to find the exact tip of the GT. So internal rotation of proximal fragment using Kelly can help to find exact entry point like this. A fracture table is helpful, but position of the patient is important. No abduction of the lower extremity. Push the shoulder push the shoulder to the opposite side. Seizure position is helpful because the traction of the contralateral side, which can help to maintain this position. In lithotomy position, the right side of traction make the movement of the trunk to the right side. So it can disturbance to the exact nail path. So another tip is modified entry point using piriformis entry. Internal rotation of proximal fragment with long Kelly provides good reduction and identification of greater trochanter tip. When you use piriformis entry, like this one, you can avoid varus reduction and you can get a good alignment. I show correction of malalignment with piriformis entry. This is the already I showed you, and she referred to my clinic 7 months after surgery. It shows non-union. So I planning the revision surgery. After removal of the previous nail, open reduction, enabled good reduction. Internal rotation with the Steinman pin can visualize the tip of the GT more accurately, like this one. The less trochanter enlarged and less trochanter small, and I can find the exact great trochanter tip like this one. So move the entry point to piriformis entry and fix the cephalomedullary nail. Bone graft and augmentation plate was also performed. The post-op X-ray shows the good alignment, and 4 months later, I acquired a bone union. Next is reduction technique for nailing. Indirect reduction, we can use Homan retractor, bone hook, Steinman pin, with joystick technique and tonsil clamp, external support. And special instrument, we can get direct reduction, such as wiring and collinear clamp. You can use bone hook to retract or use a Steinman pin to internal rotate proximal fragment. We call it joystick technique. And Homan retractor is another option, but my favorite is long Kelly. After traction and internal rotation, put the long Kelly at the level of the lesser trochanter and just lift up, and you can get good reduction like this. A very easy technique. This case is a more complex case. After internal rotation of proximal fragment, you can find the posterior sagging of the distal fragment. Another tonsil clamp or circular wiring pestle buttress the posterior sagging fragment, you can get good alignment. Post-op X-ray and the final result. Posterior sagging can reduce with external support. I will show some pictures. This is after positioning the fracture table, you can see the posterior sagging of the distal part. And manual reduction is very hard to maintain. So I use the Mayo stand to lift up the distal fragment during surgery. No assistance of the resident. So this is the Mayo stand. So the Mayo stand never disturb the surgical field. So combination of the tonsil technique, you can get a good excellent reduction and good excellent reduction. I introduced special instrument. The first one is circular pestle for wiring. Open wiring can violate biology, but this is mini open wiring can preserve biology. So this instrument is useful, especially in spiral pattern. Mini open wiring is good technique to reduce the fragment, and then you can nailing easy. This is the instrument, and put the first one and then the other one, and you can put the rolling wire and compression, and you can get good reduction. And then you put the nailing. Another instrument is collinear clamp. Probably many of you have already used it. It is a very good instrument in fracture surgery, as well as soft trochanter fracture. Coronal split case of the soft trochanter fracture, after reduction using collinear clamp, circular wiring maintained the reduction, and then nailing. The post-op X-ray shows good reduction and good alignment and good result. This case is highly comminuted fracture from high energy. Which one will use among the above techniques? Now, this case, I named the following technique as nail-assisted reduction. First, find the entry point and rimming with tonsil technique, and then insert a nail and manipulate nail and find the next fragment and pass the guide wire step by step. Repeat it the following fragment to the most distal part, and stem and pin the distal part act as a blocking screws. You can get good alignment of the whole femur. Post-op X-ray and 1 year follow-up X-ray. Recently, an instrument named reduction finger, the same concept has introduced. You can proximal limbing, and you can use the reduction finger and easily pass the guide wire and manipulate the proximal fragment and put the tip to the distal part and pass the guide wire. It's very comfortable, especially in femoral shaft isthmus type fracture. Next topic is how can we evaluate the reduction state intraoperatively? How to evaluate the varus reduction during the operation? You can use the relationship between the tip of the great trochanter and the center of the femoral head. Varus angulation of the proximal fragment increases the left arm of the fixation, resulting in femoral head fixation more superiorly than ideal. That means the risk of the cutting out. Assess varus and valgus position during surgery, like this one. So, the center of the femoral head is located below the tip of the GT. That means the varus. The center of the femoral head is proximal to the greater trochanter tip. Is valgus one normal. So you should compare the opposite side, the control arterial side of the center, and you can assume the reduction state. The last issue is how to reduce fracture gap. Traditionally, backstrike technique has been used popularly. However, it has a limitation in cephalomedullary nail. So I will show forward strike technique. This technique will be helpful to cephalomedullary nail to reduce the fracture gap. This is a 85 femur fracture in subtrochanter transverse type. And I put the nail, cephalomedullary screws, and this nail makes some distraction. So I confirmed the exact position of cephalomedullary screw and gentle tap with hammer, and you can get reduce the fracture gap. This is post-op X-ray shows good alignment without any gap. So the key points of my talk are as follows. In subtrochanter fractures, deforming force makes reduction difficulty. You always remember correct entry point and acquire reduction with various techniques. So avoid varus or flexion. In option of implant, IM nail is with cephalomedullary type is the best. Gap means non-union. So please reduce gap with forward striking technique. Thank you for your attention.
Thank you, sir. This was a nice presentation. So a few questions for you. Is there a standard trochanteric entry site for the subtrochanteric fracture?
Yes, good question. The standard entry point is just medial to greater trochanter tip. I introduced a surgical tips of the preformis entry, means especially helpful to atypical femur fractures in transverse type. I emphasize the exact entry point is medial to greater trochanter tip.
And what is your opinion regarding lateral position for the nailing?
When the lateral position is helpful in correction of the deforming force, but I prefer the fracture table. So in obese patients, I like lateral position, except that I prefer the fracture table in supine position.
And another question is, sir, can you kindly elaborate further the long Kelly technique to correct rotation?
long Kelly technique and Homan technique is similar. So you find the level of the lesser trochanter and stab wound and put the long Kelly along the anterior cortex of the femur and just lift up. And then you can get the control internal rotation and flexion deformity. It's very easy. Not wide excision, just stab wound. And you can use the lift up with the resistance of fascia lata.
And what is the role of fixation of lateral wall in PFN-A2?
That is another subtrochanteric fracture. Usually in lateral wall fracture, it means the unstable type of the intertrochanteric fracture. When you use nailing, including PFN-A2, PFN-A, the lateral wall fracture is not important because the nail supports the proximal fragment. The nail protects the movement of proximal fragment. So the nail is better in unstable type lateral wall fracture.
Thank you, sir. So over to Dr. Nasser for next presentation. Dr. Nasser.
Yes. So this is the last session, and I will move on to the lecture from Dr. Suthorn regarding the procedure for proximal fracture. It's the lecture.
Hello?
Welcome. Yes. Absolutely.
Okay. Thank you. Thanks everyone who stay until the last talk. My topic will be on the salvage procedure on the proximal femoral fracture. First of all, I believe that as a surgeon, you don't want to have any failure either from your own case or from other. However, I think you have to learn how to revise if you have to do and if the patient come to you. What I would try to speak in the 15 minutes is try to cover the three areas, which is the neck fracture, trochanteric and subtrochanteric, and showing some example of the case. How do you can detect early risk of failure before you wait until the implant breakage? And how to analyze the cause of failure before start revision? And we always discuss about refixation or arthroplasty. And what is the possible option for salvage procedure? And what do we need to achieve for success? That means to prevent another failure. For femoral neck fracture, I think everyone know that there's the reduction quality and followed by correct placement of implant, whatever you use. But if you look at this X-ray, you can imagine what's wrong with this surgeon. Each of this, I think you can discuss, but you can see immediately that why it failed. So probably treatment will never unite. Don't wait and see. And you probably need to do early revision. There are different options of implant. I will not go into detail. I think the screw fixation is still most common use. And we agree that there must be in 3-point fixation where the screw should locate. But the question is how close the screw to the bone. This is interesting study. It was shown that if both screw is not in the 3 millimeter, if both screw is in the 3 millimeter to the bone, that means it's very close, you still have, let's say, 2 cases of non-union. But if only one screw is close to 3 millimeter, it went up to 41. But if 2 screw is not in the 3 millimeter of the cortical support, the non-union is 100%. So this is very, very precise when you put the screw. Now, what happened if this young patient come to you in this 24, 35, or 29 years old? I think there's only one option to treat this kind of young patient if you want to preserve the head of the femur. And this has been published since 1989, as you can see here. This is a very many years from one of our president, Professor Reni Mati. In summary, in this 66 case, follow-up up to 26 years, he can achieve union of 88%. All the osteotomy is unite, a good excellence 62%. Now, the question is, what about the case with union with avascular necrosis, which there are 35 case, 53%. You don't need to treat, even there are some AVN. You need secondary total hip later because you cannot change the avascular necrosis, but you can save time up to 9 years, at least, or even more. Now, there's many arguments because for surgeons who do not understand what it is, they say, oh, this you create another fractures osteotomy. You could not fix because osteoporosis, which is not true, is a problem of vascularity that in fact is a mechanical problem. You will create deformity when you do total hip. You cause leg shortening. But last but not least, I think it's the question that many surgeons do not know how to operate. And they think total hip is the only option. My indication, if the patient is below 50 or some even 60, if they are in a good health, I don't care about time after operation. The bone scan has no effect on decision-making. MRI, if you do all this, you know that there are some avascular area. Neck resorption is not an issue. You still can operate. And even you have early sign of AVN is not contraindicated. As long as the head is round, I can do the operation. Now, you have to understand Powell, who explained this shearing force like this. So most of the fracture has a varus in shearing. Let's take example of this case of 75 degree if you draw the line. And you know that the resultant force from the hip is 16 plus 9, so it's a 25. So the angle that you have to correct is the pseudarthrosis angle minus 25. That means you have to use to correct the wedge of 50 degree. Let's look at this case, 23 years old, is garden tree, Powell tree. What is your concern? And look after fixation. There's a lot of mistake that you can see in this case, and the patient was left for 1 year. The poor reduction is not a good type of fixation, should use dynamic hip screw in this case. Wrong angle of the screw, wrong orientation, it's just only running into 1 point. So actually this case was failed from day one. But the surgeon waited for 1 year and want to do the total hip, and the patient is referred to me. And I want to say that there are many, many cases been neglected. It should be treated much earlier because the longer you wait, the poorer prognosis for healing and avascular necrosis. So after calculation is the 55 degree. So you minus 25. That means you have to do the osteotomy of wedge of 30 degree. Now, this is a summary of what I tried to tell. For 30 degree, you just insert this guide wire, which is the right angle to the shaft of the femur, right? For 30 degree correction. And then you're hammering the chisel, which is this parallel to this guide. And after that, you make this below. This is 2 centimeters. This is another guide wire where you insert for this 30 degree wedge of the bone, right? And then you measure the length of the blade, you're hammering in the blade. And after that, you do the osteotomy according to the KY is 30 degree. And then you insert 120 degree. That means you have 30 degree of correction, right? And after that, you complete here at the medial cortex, and then you abduct the femur. So you use 120 degree, that means you gain 30 degree of this osteotomy. Now, what about if you want to do the correction more than 30 degree? So you add another angle up here. For example, in this case, you want 50 degree. You already have here 30 degree when you put the right angle guide pin. So you add another 20 degree up here. So you do a correction of 50 degree, like this. So I think this is a simple preoperative planning. I prefer to operate on normal lateral lucent table, not on the fracture table, because it's easy for me to manipulate, right? So this is the real case where exactly what I show you in the pre-op planning. The correction is 30 degree. So you put in the guide wire, you put the hammer chisel in, and after this 2 centimeter, you make the wedge here of the bone of 30 degrees like this. And then you abduct the femur. Don't push this plate to the bone. You abduct the femur to the plate to avoid cutout of the blade. All right? So it's end up like this. So now you correct from 55 degree to 25 degree, which is perpendicular to the resultant force. And this is 1 year follow-up at heel. Another case of 19 years old is look like this, varus deformity, shearing of 65 degree. We want to make correction of 40 degree. Unfortunately, there are screw here, which is in the place that you want to do more. So we can only do 30 degree correction. And this is the step, as I already explained to you in the planning and in the real operation. So this is the pre-op and this is the post-op. So now you see the osteotomy and just osteotomy line here, and this is the fracture. And this is a 1 year follow-up. Although the angle is not what we want to correct, but look at the function and look at how the patient is walking, right? So I think in this young patient, this kind of operation is very useful. Now, let's come to the intertrochanteric fractures that you can see this kind of failure. I think both plate and nail has a successful cases, and also sometimes you have a failed case. So it can be fail or it can be successful, depend on how well you perform your operation. Now, what are the risk factors of this implant failure? If you have a varus reduction of the fracture, if the neck shaft angle is not correct, they have a major gap at the fracture side, you don't have a medial column support, you have a wrong placement or wrong position of the implant, and on the follow-up, you see that implant change the position. If you do extensive dissection for open reduction, and is there no progress of the healing, you can expect that all of this risk factor lead to the failure. Look at this case, right? This is a post-op. You see a big gap here, all right? And then in the 3 months, the gap even widened, and in the 5 months, it's failed. It's simple to predict the case that will fail, but usually it's not from the surgeon who operates. He always said, oh, it's fine, it's good. Again, when you follow up, if you see something like this, you see it's unstable, you see that the screw is migration, then you need to revise in order to save the hip. And I suggest that we use this reverse DF rather than try to insert another nail, because there's a big hole already in the head of the femur. Now, when you do any kind of correction, make sure that you make the neck shaft angle right. You have a stable reduction with medial contact, no varus of the fracture side, compression of the fracture side in case of the non-union, or sometimes you have to need the bone graft and so on. So there are possible salvage procedure is either you revise the fixation by direct open reduction, Walker stable reduction, or you do medialization with or without osteotomy is Diamond Houston. You rest on neck shaft ankle, you reduction and refixation. And then you decide whether you use the same type of plate or a different type of plate. I show you this case, which is reverse obliquity. This is the post-op X-ray. There's slight varus, there's a small gap here, right? On the follow-up, the plate broke at the 5th month and the patient waited until 8 months before he came. And you can see now it's become the varus of 105 degree. Now, you have to achieve the operation, the fixation by correct neck shaft ankle, compressed fracture size, and then you reduce the fracture. It is very difficult to reduce this severe varus by nail. So it's clear that the plate will help you. Now, if you look at this plate, you know that the second screw here is 120 degree, right? Before it's break. So this is already the good landmark for you. So when you insert this guide pin, and then you check AP X-ray, lateral X-ray is correct, I just hammering in the blade. There's enough space to enter the blade. And then I put the blade 130 degree after hammering the chisel. And after reduction, I gain from this 120 additional 10 degree. So now you see that the neck shaft is correct. And this is 15 months after follow-up. Now, this is the case, typical old patient, a lot of comorbidity, unstable intertrochanteric. And this is what happened after operation. You see this big gap. What do you think in this case? What will happen? 2 weeks looks fine, but after 3 weeks, you see that the hip screw is migrating backward, and the patient has some inflammation, so we have to do debridement and remove the implant, and we send for culture. Fortunately, there is no any bacteria. So this is 3 weeks after removal of implant. What will you do now with this situation? There are different options. You want to put the nail again, or you want to change to the plate, or you want to change to the total hip or some kind of arthroplasty. My decision is to try it again by doing this, what we call diamond histone. This is the technique very old, you see 1967, by inserting the blade into directly from the fracture here, and then you reduce to the shaft like this. So the key is to put the spine of the head and neck into the shaft like this, and then hammering in the chisel. After you check alignment, APOA lateral, and then you reduce the plate, the side plate to the bone. I put in the bone graft taken from the greater trochanter, and then I do the fiber Y to hold the greater trochanter like this. So this is the post-op X-ray in 2 months, and this is 1 week after operation. The patient start ambulation, and this is 1 year follow-up. Now, the last case is the subtrochanteric. This is the case where you put the nail. I think you already listened to the very good lectures that the entry point is the key. So this is 1 year. The patient still have pain because of the varus deformity in this case. So the problem is non-union, varus deformity, and shortening. So the current evidence confirmed that IM nail probably is slightly better from the extramedullary. However, if the result is the same for intra or extra, once you have a stable and reduce the fracture, no varus. Now, for the nail, I want to show you there's a high incidence of varus deformity because of a wrong entry point. And why? Because of deforming force or whatever you have listened already. Right? So entry point is critical and associated with correct position of the proximal part. If you look on the malalignment, this is the reason I explained to you. Of course, it's also related with how you are experienced using the fracture table. Because in fracture table, it's not easy to reduce. You have to learn a different technique. So first of all, we already confirmed by CT, it is a non-union. So now we have to think about whether we use the nail again or we use the plate for correction. But in this case, we decided to use the plate because we want to correct the varus deformity. Maybe it's simple, better than using the nail to correct, and we want to compress the fracture site. So this is the, after opening, you see, this is a confirm, it's a non-union. And then we use this reverse distal femoral plate, checking direction of the screw, insert the screw proximally. We do the manual traction, and we use this tension device to achieve compression, like this. Of course, there's a lot of bone graft, it's a local graft that we can take out from the fracture area. And this is a follow-up and 6 months after revision. So the take-home message for me, for the proximal femur, you still see a lot of complication. You must make a careful analysis of the fractures, and then you think about the different options and select what you think this is should be the first option. You focus on why and how to use that implant. I don't care whether it's a plate or nail. You have to know how to put it correctly. And then you plan step by step, which is very important. Good reduction, biological reduction, either indirect or direct reduction should be biological, and a good fixation technique. And after that, when you follow up and if you detect any risk factor, if you see that there are chance of the failure, please do early revision before irreversible damage, and you cannot save the hip joint. Thank you very much for your attention.
Thank you so much for your great talk. So I have 3 questions regarding the lecture. First one is, should we do primary bone grafting in cases where we are apprehensive of union?
Try to, sorry, like,
Or should I repeat the question?
Yes, please.
Should we do primary bone grafting in cases where we are, it says apprehensive of union? Probably a bit
primary bone graft in case of intertrochanteric fractures, or in which case?
The person who asked the question did not clarify the part.
Okay, let's say in general, we don't do the primary bone graft if you don't dissect or you don't destroy a vascularity around the area of fracture zone, right? Mm-hmm. And today, if with a nailing technique, you don't open the fracture size unless you need to do some kind of reduction, or even the plating in subtrochanteric or some intertrochanteric. When you use plate, we always do with MIPO technique. So for me, primary bone graft is not used as a routine, and rarely to do the primary bone graft. Mm-hmm. You can follow up maybe 1 month or 2 months, and if you think there is a need, then you can do a secondary bone graft. Let's say like that.
The second question is, what is your opinion on tamponade decompression in fracture neck?
To do the compression at the fracture neck?
Yeah, it says
they're asking about temponade decompression.
Oh, I see. I think in pediatric, this is strongly recommend that you have to at least open the blood because the capsule, everything is thick. But in adult, it's still controversy. However, I don't see any disadvantage. You know, if you are close by at that area, maybe you can do a little bit of a knife to stick and have a bleeding coming out. But I believe that there is still controversy under discussion. But mainly, we do only in children, not in adult.
And the third question is, would you recommend reverse distal femoral LCP for fixation of subtropranteric fractures?
I think in subtrochanteric, if I may say, nails still can be the first option. Mm-hmm. Unless when you look at the X-ray, and then when you see that there are very difficult to align the canal. For example, there are many fragments, and you think to align the canal will be difficult because for the nail, it's not just the entry point. You have to align the canal in order to pass the nail in. Mm-hmm. In that case, I may decide to use the plate if the proximal fragment is long enough. And I use anatomical plate, which can be any kind. Once I fix proximally well, then I can align the side plate to the shaft by my MIPO techniques. But the key is you have to fix proximal part with anatomical plate in anatomical position. So for me, I will have no fixed idea whether the nail and the plate, which one is better. I will look into individual case and see what is the most benefit of either nail or plate. However, most of the time, even I do the nail, I will not do on fracture table. Of course, for those who are experienced using fracture table, they can do it very well. But I believe that in my hand, it's more simple to operate on normal operating table because the reduction is much simple.
Okay, and the last question is, what is a post-operative protocol? So after your revision fixations, do you still do early ambulation for the patients?
Yeah. In every surgery, I think you must provide enough stability, to allow motion, of course, and to allow partial weight bearing with support. And if the patient has no pain or the fracture stability is good, simple fractures, you can allow more weight. I do not believe in non-weight bearing anymore. I strongly convince the patient to bear the weight. Partial weight with the support depend on, let's say the condition of the patient. I think the non-weight bearing should not apply. And even with a non-weight bearing, it doesn't help anything if your fixation is not strong. Because even lying on bed and just moving and turning, right? If your fixation is bad, it will fail. It's not because of the weight bearing. So this is my philosophy.
Thank you. That was so understandable. And
Mary,
that was
sorry, if Mary, you permit, I would want to ask the faculty, all of them, just one question. Of late, when you see presentations across the globe, international congresses, we see multiple fixations, the uses of multiple fixations becoming more and more popular. I see neck fractures being fixed with the fixation systems with small fragment, 2 plates on the medial part. You see intramedullary nails and then lateral plates and medial plates. So what, in your opinion, is it just all of a sudden fractures have started demanding more fixation, or we have gotten into the habit of putting in more implants?
Good question, Jamal. Okay, maybe I reply first.
Yes.
For medial neck fracture, if you have comminution in high energy after you fix the neck and you still have the medial column which is maybe comminuted, you may apply a small plate. But that is not because I want to put the plate, too many plate, but because there is no medial bone contact. That is the only reason that I put there. You see now there are more, in case of tibial plateau, distal femur, where you put the medial plate in periprosthetic. My answer to that is, if you put the plate on one side, number one, if you have a good vascularity on the opposite side, and if you have a good bone contact on the opposite side, and the lateral fixation, like in the distal femur, is strong enough, you don't need any medial plate on the opposite side. But in case of periprosthetic, where the lateral fixation is not strong, you have a very comminuted, you have no good bone contact on the medial side, or bone loss or whatever, you may apply the plate on the opposite side. But I can understand your point that you have seen more and more. They try to put even the mini plate on the every fragment of the fracture. I think that is not the right philosophy. They just want to make the X-ray look nice. So if you want to put the plate there, you must have a good reason, not just a fashion.
Yeah, I mean, Roger, if you could answer that. I see X-rays, fabulous looking X-rays, 4 small plates, 4 mini plates, and 1 hip fixation. So why has this happened of late for the past few years?
Yeah, look, I think it's really happened because we've appreciated that with neck fractures, reduction is so important. So it became about the device primarily with sliding hip screw, cannulated screws, whatever. But then it became about, look, let's do a reduction typically an anterior approach to get the fracture exactly where it needs to be. And people were using plates either anteriorly or medially or combination, 2-0, 2-4 type plates, and they were getting the reduction and holding it there to get their implants in. Then the question became whether or not you left the plates there, whether or not that actually worked against a sliding type hip screw, whether or not it allowed cannulated screws to actually slide if they were partially threaded. So the combination of plates there for obtaining reduction versus holding the reduction was the next step. So speaking of neck fractures, it's certainly very common to put them on, and depending on whether you can compress and hold your fracture there, to me, determines whether or not you leave them there. For me, if a vertical neck fracture is what I'm dealing with, or there's any kind of comminution, I'll tend to put them on and leave them on. But look, it's so hard to give you a one-size-fits-all yes or no answer. I think small plates, 2-0, 2.4 type plates are very useful in femoral neck fractures. I use them a lot in subtrope fractures to get a reduction. A lot of the times I'll take them off, but, they're very useful for holding bones where you want them to be. I'll stop there.
Thank you, Roger, and thank you, Jamal, for an interesting question. So in the interest of time, I'd like to thank everyone. It's been a terrific webinar. I'd like to thank our young moderators, Christina Marie Joseph and Damon Yar, and Natsumi Saka for doing a great job, and also the wealth of knowledge that we've been able to listen to and to hopefully reflect upon and may influence our practice that's been provided by Ramesh Sen, Roger Bingham, Mk Wong, Jiwan Kim, and our Suthorn. And I think it's, reflecting on Suthorn's experience, which is long and vast and very wise, one of the things that I took home was, if something's not going right, do not wait until the changes are irreversible before you make a decision to make it better. So in light of that, I'd like to thank all of our faculty. I'd like to thank you as participants for all your great questions, and we'll see you for our next one. Have a good day or good night, and enjoy yourselves. Bye now.
Thank you. Bye-bye, Manish.
Thank you.
Thank
Okay,
you.
so we are off air now. You all can communicate among yourselves. We are off air.
Good job. That was a really good set of talks. Thank you, everyone, for putting in that time. I think it really helps our young and sometimes our older people in the Asia-Pacific region and hopefully globally. So did you guys feel you had enough time to present your talks?
I was a bit challenged, so I was rushing a bit. So sorry.
Okay, not a problem. All right. Well, enjoy your day. Have a terrific rest of the day, and we'll see you at the next meeting. Hopefully at some stage in person, but we'll wait for the immunizations. Good luck.
Thanks for watching.
Goodbye.
Bye.
Yeah, bye-bye.
Recording stopped.